Namaskar, dear viewers. Welcome to today's session of critical care webinars. And today the topic is clinical approach to shock. And the speaker today is Dr. SRINIVAS Samavedam, who is, I think, well known to most of you who are from India at least. And Dr. SRINIVAS Samavedam is the Chief Critical Care Specialist at the Ramdev Rao Hospital, Hyderabad. He is the president of the Indian Society of Critical Care Medicine and was the scientific chairman for the Critical Care Conference at Kochi 2025. And he has authored several publications, several book chapters. He's also a holder of diploma in medical law and ethics, and also masters in data analysis and machine learning, amongst various other accomplishments. And he's a very prominent member in Intensive Care Society of India. And like I said, he's the president of the Indian Society of Critical Care Medicine, and he's a great educator. So with that, I'll hand it over to you, Dr. Samavedam. Kindly proceed.
Good evening, friends. Good evening, Dr. Tapesh and all the Young India intensivists. Thank you yet again for giving me this opportunity of interacting with you on a topic of significance to every specialty that handles emergency patients, and that is an approach to shock. Today, I'm exclusively going to talk about how you make a clinical approach to shock, although ultrasound is an integral part of an approach to shock. But there may be certain situations where sonography is not accessible to you or is not possible because of technical issues like a surgical emphysema, lot of dressings, and whatever it may be. And long before sonology came into ICU practice, shock was made, the diagnosis and approach to shock was made on the basis of clinical parameters only. So let us look at how you can approach a shock from a clinical perspective. It is one of the most frequent indications for ICU admissions. Shock and hypoxia are the two most common indications why patients get admitted to the ICU either from the emergency room or get transferred in from the wards. Quite often in intensive care practice, shock is multifactorial. For example, you have a patient with polytrauma. The most common element is hemorrhagic hypovolemic shock, but you could also get an obstructive shock because of a tension pneumothorax, and you could get myocardial contusion with cardiogenic shock also happening in the In patients in the intensive care unit, multiple organs are often involved when you are managing patients with shock, and your approach should include assessment of all these organs. But to avoid shock from becoming a cause of mortality, your quick response is probably the most crucial element because, as I mentioned before, overlaps are common. A patient with septic shock can develop a cardiogenic shock. A patient with cardiogenic shock can develop an obstructive shock. So, overlaps are common. And as practitioners of critical care medicine, you need to be aware that the initial diagnosis of the is not always the only reason for somebody developing shock in the intensive care unit. At that particular point of time, what is the hemodynamic profile of the individual determines what the etiology of shock is. So we will try to look at the definition of what is shock, what are the types of shock and their etiologies, what are the clinical features which help you to discriminate these of shock in varieties of shock in the um, uh, what are the different clinical features which help you to understand the etiology of the shock with a diagnostic and a therapeutic. So when you talk about definition of shock, shock is an imbalance in the tissue oxygen demand and supply. So it is not always low blood elevated lactate. Um, it's not about elevated lactate or a low blood pressure that's essential for a diagnosis of shock. Wherever you find an imbalance between the demand and supply of oxygen, That is the pathophysiological definition of shock. It is a state in which a profound and widespread reduction of effective tissue perfusion results in first initially a reversible cellular injury, and then if you don't resuscitate it in time or appropriately, it results in irreversible cellular. Once irreversible cellular injury is set in, irrespective of how aggressively you treat the patient, the outcome is usually adverse. In this context, it's always important to remember that there is no single number or a range of numbers which defines what is a normal cardiac output for a person. For example, somebody sitting in a chair talking to people, his cardiac output of 3.5 or 4 liters is good enough for him. But if that person is running on a treadmill at 8 kilometers an hour with an inclination of 10 degrees, 5-liter cardiac output may be a low cardiac output. Same person with the same comorbid conditions. So you cannot, what is normal cardiac output should not be described in terms of a number, but in terms of the cardiac output which can meet the body's metabolic requirements and demands and does not result in a oxygen supply demand inequality will be the appropriate definition of normal cardiac. So when this output is compromised by different mechanisms, you get the four major types of shock. That is the distributive shock, the cardiogenic shock, the obstructive shock, and the hypovolemic shock. I did not include endocrine shock in this because it will complicate the issue, and it's a different ball game altogether in the intensive care unit. So traditionally, we have been told that the approach to a hemodynamically unstable patient should be looked at from the tank, the pump, and the pipes. That means the intravascular volume, the heart, and the peripheral blood vasculature. Any abnormality in any one or more of these components results in a low at the end of that pipe, which you can see, which results in a low cardiac state, which results in shock. This is the simplified version of the approach to a shock. So there can be problem with the pump, there can be problem with the tank, there can be problem with the pipes, or there may be a block in all these pipes, which may be resulting in obstructive shock. So if you have a patient when whose tank is empty, it results in, it is the typical situation is a hypovolemic shock, a gastroenteritis, for example, a cholera, for example, a burns patient, for example, or a hemorrhagic shock, for example. If you say the pump is weak, that means it's the cardiogenic shock, where the heart is not pumping weakly enough. A toxic myocarditis, for example, a drug-induced myocardial depression, for example, a cardiogenic shock, a acute coronary syndrome with myocardial stunning, for example. Pipes are leaking. That means the vascular permeability is very high, systemic vascular resistance is very low, and there is a distributive shock. The heart is pumping, there is water in the tank, but the water, instead of coming in the tap, is leaking out from the perforations in the pipe. That is distributive shock, typically seen in sepsis, but can also be seen in neurogenic shock. The pipes are blocked, the heart is pumping, the pipes are intact, and the tank is full, but there is no flow that is coming at the end of the tap. That means there is something that is clogging those pipes. That is obstructive shock. On the right side, it is pulmonary thromboembolism. On the left side, you can look at pericardial tamponade or any other, or even a tension pneumothorax on either side. These are the prototype conditions which result in obstructive shock. So this is the summary of what all I spoke about the etiological causes. So you have somebody who has hemorrhages, GI losses, dehydration, you get a hypovolemic shock. Distributive shock is a type of a relative hypovolemic shock because the capillary leak results in loss of intravascular volume into the extravascular interstitial space. So there is always relative hypovolemia in patients with distributive shock, and that's the reason you assess the volume status always in patients with distributive shock. And your response is always to give fluids to these patients. When you have a patient with myocardial infarction, myocarditis, arrhythmias, aortic stenosis, cardiac tamponade, tension pneumothorax, pulmonary embolism, core pulmonary. These are all causes of cardiogenic shock, either because of obstruction or because of myocardial weakness. So let us look at the features of a distributive shock. This is the most common type of shock which intensivists see in their practice. So in distributive shock, the vessels dilate, causing a relative hypovolemia, as I said, and a reduction in the systemic vascular resistance. As a result of this systemic vascular resistance, there is capillary leak, which causes hypovolemia, and it aggravates, causing edema in the interstitium and sometimes pulmonary edema. So the changes will result in a fall in the blood pressure. The systolic blood pressure falls. The diastolic blood pressure also falls. The pulse pressure widens, and the peripheries are usually formed because there is a low systemic vascular resistance in the initial stages. So in this type of shock, your clinical features would be there is a tachy. So the cardiac out is always a reflection of the stroke volume and the heart rate. So the first response to a decrease in cardiac output is increase in heart rate. So these patients usually have a high heart rate. Because there is a vasodilatation, the diastolic pressure is very low, as a result of which there is a widened pulse pressure and peripheries are warm. Because of the relative hypovolemia, you don't find an elevation in jugular venous pressure. Edema, like a gross edema, like a hepatojugular reflux, pedal edema, sacral pitting are usually absent. The lungs are usually clear except for evidence of an infection like a consolidation. And because of the hyperdynamic nature of this condition, the first heart sound is usually hyperdynamic and is loud in patients with distributive shock. When you come to cardiogenic shock, there is a sympathetic overactivity which results in vasoconstriction. Because of the low cardiac output, there is the activation of the angiotensin system which causes vasoconstriction. Although the systolic blood pressure falls, the diastolic is usually higher, so the pulse pressure is usually narrow in patients with cardiogenic shock. But because the forward flow from the left side of the heart is not adequate, there is damming back of blood on the right side. So there is a high venous pressure, which results in engorged veins and fluid extravasation into the serous cavities as well as into the interstitium, causing edema. So the clinical features of these patients are usually a heart rate is variable. You could get myocarditis patients and endocarditis patients would have a tachycardia. Those with beta blocker overdose, those with heart blocks can have a bradycardia. So the heart rates, there could be arrhythmias also. You could have atrial fibrillations. You could have ventricular tachycardias. The heart rate, therefore, is variable in patients with cardiogenic shock. As I mentioned, the diastolic blood pressure is usually higher and the pulse pressure is usually narrow. But because of the decrease in the forward flow, the peripheries are cold and the JVP is distended. The jugular venous pressure is elevated. Edema is usually prominent, and an auscultation of the lungs, you get crepitations in the bases where gravity drives the fluid down into the lower zones of the lung. A non-compliant heart result in a third ventricle, a third and fourth heart sounds of left ventricular or right ventricular of either ventricular origin. So this is the clinical features which will help you to differentiate a cardiogenic shock from a distributive shock. So you have a warm peripheries, wide pulse pressure, tachycardia with absent JVP, you are probably dealing with a distributive shock. You have cold peripheries, narrow pulse pressure, JVP elevated, creps at the bases, edema everywhere. You are probably dealing with a cardiac shock. So this is not always a compartment that somebody with sepsis cannot have this presentation. But when this presentation happens in a patient with sepsis, you can assume that there is some myocardial component to the septic process. Hypovolemic shock is probably the simplest of all these and probably the easiest to treat. And this is something which no patient in intensive care should die. Here also, there is a sympathetic overactivity leading to vasoconstriction. Here also, the peripheries are cold, diastolic pressure is high, and the pulse pressure is narrow. But in this condition, The heart rate is high, again, an attempt to maintain a normal cardiac output. The diastolic pressure is increased because, as a response to vasoconstriction, the peripheries are cold and the diastolic pressure is narrow. The pulse pressure is also narrow in these patients. The peripheries are cold because of this, but because the entire tank is empty, the JVP is flat. The venous, there is no engorgement of the veins in hyposhock. There is no edema. The lungs are clear, but because of the tachycardia that is trying to increase the cardiac output, like in distributive shock, you get a hyperdynamic loud first heart sound in patients with hyposhock. So, loud first heart sound with cold peripheries is probably hypovolemic shock. A loud first heart sound with warm peripheries is probably distributive shock. That's how you differentiate. A narrow pulse pressure with cold peripheries is and absent edema is probably hypovolemic shock. A narrow pulse pressure with edema and a high diastolic blood pressure is probably cardiogenic shock. Third heart sound more often in cardiogenic shock. First heart sound loud in hypovolemic shock. So this is how you differentiate between these three different types of shock. Then you look at obstructive shock, where the myocardium, either of the right side or of the left side, is constricting against a high afterload. This also results in sympathetic overactivity and there is venous congestion. So you could have aortic stenosis, you could have pericardial tamponade, you could have pulmonary thromboembolism, you could have tension pneumothorax. So in this condition, you will have high heart rate and a lower you will have an equalization of the pressures. The diastolic pressure, the jugular venous pressure will all be equalized in patients with cardiac tamponade. The pulse pressure is narrow and the diastolic blood pressure is variable. Pulsus paradoxus is an important differentiating aspect for patients with obstructive shock. Here, the heart sounds are muffled if there is a pericardial effusion. If there is a pulmonary hypertension, you could get a loud second heart sound, the Graham still. So these are the features which help you to suspect that your patient probably has a obstructive shock. So what are the investigations you would like to narrow down the etiological cause? In distributive shock, it is very straightforward. You look at the blood picture to look at polymorphonuclear leukocytosis with band forms. You look at the lactate to see if there is a hypoperfusion related hyperlactatemia and lactic acidosis. You look at the renal perfusion by looking at the blood urea, nitrogen, and creatinine. You probably would send cultures if you are suspecting an infective process. And of course, you do appropriate imaging like a chest x-ray or an ultrasound or a CT scan or whatever. In cardiogenic shock, the investigations you do or you look at the ECG to see whether there is acute investigation, there is an ST elevation, or there is a arrhythmia that is you have missed. You look at evidence of myocardial myocyte injury by looking at the troponin. You will screen for ventricular stretch by looking at the troponin, by looking at the BNP, and you would do imaging like a CT pulmonary angiogram or a coronary angiogram or an aortogram if you are suspecting a dissection of the aorta. When you want to, there's not much of testing you do for hypovolemic shock, but definitely you need to look at the CBC to see are you dealing with a dengue with a thrombocytopenia induced capillary leak. You need to do grouping because if you have to replace blood and blood products, you need the group in hand, and you will also want to look at where the blood is using a ruptured ectopic, for example, for which will help treat the patient faster. In obstructive shock, you probably will have only imaging to help you. Of course, the presence of the Beck's triad, venous congestion, arterial hypotension, muffled heart sounds is one of the features of pericardial tamponade, but that's a late feature. So ECG would show low voltage complexes, chest X-ray would show a tension pneumothorax, but CTPA, HRCT, or some of the tests you would do for patients with obstructive shock. What is the specific monitoring you would do in some of these situations? In distributive shock, there are a few things which you should look. The poor man's cardiac output. You need to look at the urine output of all these patients. If somebody who's come to you with a urine output of less than 0.3 mils per kg per hour, if you resuscitate him, well, if the next hour the output is gone up to 0.5 mils per kg per hour, probably your hyperperfusion state is getting better. So that means your lactate would resolve. If you have invasive hemodynamic ability in your institute, you could look at stroke volume variation. Biomarkers like CRP, like procalcitonin, can help you to identify what type of infection you are dealing with and what is the response to your antimicrobial therapy. For cardiogenic shock, you probably have to look at serial ECGs to make sure the rhythm is under control, some kind of assessment of cardiac output with a PICO or even a pulmonary artery catheter. You look at biomarkers. Is my BNP resolving? Is my troponin I settling? These are some of the biomarkers which you can use. And electrolytes. Hypomagnesemia, common cause of ventricular arrhythmias. Hypokalemia, common cause of supraventricular arrhythmias. Hypocalcemia, common cause of long intervals. So you should be looking at some of these aspects as well. In hypovolemic shock, not much of monitoring again, as I said, but your urine output and your stroke volume variation should be able to tell you whether your resuscitation is going in the right direction or not. In obstructive shock, again, not much. You can look at the cardiac output, you look at capillary refill time, and you can understand that your peripheral perfusion after draining the pneumothorax or putting a pigtail into the pericardium has it actually improved your capillary refill time. That can tell you that your cardiac output is actually getting better. What about focused therapy? How do you treat this in a focused way? Distributive shock prototype is sepsis, so you will go with early aggressive fluid therapy. At the same time, you should not overdo fluid therapy in these patients because positive balance after 24 hours is an independent predictor for adverse outcome among these patients. If it is a septic process, start antimicrobials early and start them in an appropriate way. Vasopressors, better to initiate them early rather than wait till the shock is refractory. If the acidosis is bad, patient is oliguric, is hyperkalemic, consider some form of renal replacement therapy. If it is the hemoglobin is less than 7 grams, try to improve the oxygen delivery by improving the hematocrit to 21%. Blood purification, we don't know whether it has a role, but we have to consider that as well. In cardiogenic shock, you have to look at revascularization, whether it's the coronaries or the pulmonary vasculature, you need to look at revascularization. Control the rhythm. Control first 24 hours or 48 hours, your focus should be on controlling the rhythm in a new onset arrhythmia. But after that, if you're not able to do it, at least improve the diastolic filling of the heart by controlling the rate. Sometimes you may have to use inotropes or inodilators. And in refractory cases, maybe you should consider mechanical support like IABP or a veno-arterial ECMO, and in the advanced stages, maybe a ventricular assist device as well. Hypovolemic shock, simple to treat, fluids, blood, surgery to stop the bleeding, and renal replacement therapy, correct the acidosis and hyperkalemia. Obstructive shock intervention early. So you do relieve the obstruction, you thrombolize these patients, and you offer surgery if your conservative therapy is not successful. So that is about the hardcore clinical approach to patients with different types of shock. But I'll give you a different perspective now. All this business about giving fluids, vasopressors, inotropes, blood is about maintaining the oxygen delivery to the tissues. So, how do you assess that these tissues are good? And based on these markers of oxygenation, can you discriminate between different types of shock? So, we will look at how to use the venous oxygen saturation in the superior vena cava and the arteriovenous carbon dioxide difference. That means the difference between the PaCO2 on an ABG and the PvCO2 on a VBG. How does it help you to discriminate the type of shock is something we look at. What is this SvO2? It is the percentage of oxygen that is bound to the hemoglobin in the blood that is returning to the right side of the heart. For example, if I am giving 98% oxygen at the left ventricle, after when it ejects from the aorta, that blood has 98% oxygen. So when it comes back to the periphery, some amount of oxygen is extracted, about 20% or 25%. So the blood that is coming back to the venous side has about 70 to 65 to 70% saturation. So this is the SvO2. So 25% is the delivery that is happening in the peripheries. That means it is reflects the amount of oxygen left over after the tissues remove what they need. It's like your bank balance. So when your bank, your credit account is credited with your salary, the bank takes whatever it wants from EMI, and what is left is SVO. So this number has been traditionally used to recognize when a patient's body is extracting more oxygen than normally. So suppose somebody's venous oxygen is 60%. That means instead of 20%, 30% or 40% is being extracted in the periphery, so the demand is more. On the other hand, if somebody's oxygen saturation in the venous side is 80%, that means oxygen is not getting offloaded. So the tissues are actually hypoxemic. An increase in the extraction, like a low venous oxygen saturation, is the body's way to meet the tissue oxygen demand when the amount of oxygen is less. So when the supply is less, they try to extract more and they become more avid extractors of oxygen. So, what is the rationale of using this SpO2 in hemodynamic assessment? The SpO2 is a compensation for increased demand, and the first response to this increased demand, as I said, is an increase in the cardiac output. So, the oxygen delivery is determined by the cardiac output times the oxygen content of the blood. So, the determinants of this oxygen delivery are your heart rate, your stroke volume, your hemoglobin, and your saturation of oxygen in the arterial blood. So this is the normal. So the stroke volume increases, the heart rate increases, and you try to give more oxygen. The second response is the tissue oxygen extraction being increased. So from the standard 24-25%, it goes up to 40%. The final response is that it blunts itself. So it doesn't extract anymore. It starts its own anaerobic metabolism. That's when your lactate starts going up. So the fundamental causes of a low SVO are: one, the cardiac output is not high enough to meet the tissue oxygen demand, or the hemoglobin is very low, as in hemorrhagic shock. The SaO2 is too low, like in hypoxic conditions, but the oxygen consumption has increased without an increase in oxygen delivery. This is typical of distributive shock. So this is the conditions, the rise and fall of SCVO2. SVO2 and SCVO2 fall when there is an increased consumption or a decreased delivery. An increased consumption happens because of pain, shivering, agitation, and hyperthermia. A decreased delivery happens in hypovolemia, hypoxia, anemia, abnormal hemoglobin, and in heart failure. An increase in SVO2 happens when there is a decreased consumption, as happens in sedation and respiratory support, or an increased delivery like using an inotropic agent. What are the aspects which influence the SVO2? So, in the perioperative period, as I said, these are all the factors. So, for a critical care perspective, I would be more worried when with a very high SVO. When the SVO2 is more than 75%, that means irrespective of how much oxygen I'm giving to the left side of the heart, the tissues are not extracting them. That means they have become paralyzed. So you need to look at other modalities of reactivating them, like giving them thiamine, giving them methylene blue. So this is something we need to be looking at all the time in our patients. So it is applicable in heart failure, it's applicable in trauma, it is applicable in high-risk perioperative surgery patients and among patients with sepsis and septic shock. Then we look at what is the carbon dioxide gap. The carbon dioxide gap, the delta CO2, is the difference between the mixed venous content and the arterial content of carbon dioxide, and it reflects the balance between its production by the tissues and its elimination through the lungs. Elimination through the lungs is a direct reflection of the cardiac output. The veno-arterial difference in carbon dioxide can be estimated at the bedside by veno-arterial difference in PCO2, named the PCO2 gap or the delta PCO2. The difference between the PaCO2 and the PvCO2 is the delta PCO2, and this delta CO2 gap is something which reflects whether there is a low cardiac output or a high normal cardiac output. So, what are the determinants of this carbon dioxide gap? The venous side is again a difference between the arteriovenous carbon dioxide difference and the cardiac output. Under physiological conditions, the content of carbon dioxide can be substituted by the PCO2. So instead of content, you are looking at partial pressure. So PaCO2 and PbCO2 can be surrogates of CaCO2 and CvCO2. So the delta PCO2 the delta CO2 is equal to the product of a constant and the difference between venous and arterial carbon dioxide content. And if you inverse that equation, the venous the carbon dioxide is a reflection of the cardiac output. So the lower the cardiac output, higher the delta PCO2. If you reverse that equation, the delta PCO2 is inversely proportional to the cardiac. So this is how it looks like. You look at a patient with tissue hypoxia and you look at somebody who has a reduced systemic blood flow versus somebody who has a normal systemic blood flow with a cardiac output that is at 8 liters per minute. You can see in this diagram at a cardiac output of 8 liters per minute, the PaCO2, the arterial side is 40. So at that high cardiac output, more carbon dioxide is brought in. The tissues bring in lesser carbon dioxide and the venous carbon dioxide is less. But in a low cardiac output state where there is tissue stagnation, the PV, the venous CO2 is higher at 52 millimeters of mercury because of stagnation of the or more buildup of carbon dioxide in the tissue. So the delta PCO2 of more than 6 millimeters of mercury reflects a reduced systemic blood flow. Is one of the methods of assessing. So if you look at the cardiac output versus the AVCO2 delta, a cardiac output of less than 2 liters or what is defined as a cardiogenic shock correlates with an AVCO2 delta of about 6 millimeters of mercury. So it can be used as a surrogate of cardiac dysfunction or cardiac origin of the shock. So in stagnant hypoxia, as in a low cardiac output, the AVCO2 gap is highly relevant. In anemic hypoxia, maybe it is not as relevant. In cytotoxic hypoxia, it remains unchanged. In sepsis patients, a high arteriovenous carbon dioxide delta in early phase would indicate a worse prognosis because it suggests microcirculatory disturbances with normal lactate. So if you have a patient who is in shock and you have an SVO2, which I described earlier, you have two situations where the SVO2 is less than 70% or the SVO2 is more than 70%. If the patient has an SVO2 of less than 70%, you look at the hemoglobin. If the hemoglobin is more than 7 grams or more than 21% hematocrit, you look at the saturation of arterial oxygen. If the saturation is normal, then you could probably transfuse the patient. If the saturation is low, you improve the oxygenation by increasing the cardiac output. On the other hand, if you have somebody whose SVO2 is more than 70%, you look at the delta PCO2. If the delta PCO2 is more than 6, it's a cardiac problem. But if the delta PCO2 is less than 6, there is no benefit expected from an increase in cardiac output. But if you have more than 70%, you can look at the ratio of the delta PCO2 to the the content of arteriovenous oxygen, and you can find out whether there is other causes of hyperlactemia. And either way, if you want to increase the cardiac output, you could assess for fluid responsiveness by looking at stroke volume variation, or you can assess cardiac contractility by echocardiography. So if you have a patient with an you try to keep the mean arterial pressure more than 60 and lactate less than 2 and look at the SVO2. A low SVO2, as I said, should look at either hemoglobin or oxygen. A high SVO2, you should look at the AVCO delta. And then if it is, then try to see whether the patient is fluid responsive or not for you to triage your patients into anemic, hypoxemic, cardiogenic, distributive, and hypovolemic shock. If all else fails, we are looking at cytopathic hypoxia, these patients. So if you look at lactate as your beginning point of resuscitation, which most of us do, let us look at how you can use lactate to get into this algorithm. So you have a patient whose lactate is more than 2. That means you're suspecting there is shock. So you look at the SVO2. If the SVO2 is less than 70, you look at the AVCO2 delta. If the AVCO2 delta is less than 6, you are looking at anemic hypoxia. A lactate, high lactate with a low SCVO2 and a high CO2 mean low cardiac output. So this is how you can use your lactate for starting point. Somebody who is normal lactate but has a high SBO should be looking at again AVCO, and you could probably identify those who have microcirculatory alterations without dysoxia. So in summary, shock is an imbalance between metabolic demand and supply. There are four main pathophysiological types with distinct clinical patterns. Clinical assessment can result in identifying the pathophysiological mechanism in 90% of the cases. Early identification is the key. A judicious use of clinical examination, SVO2, lactate, and arteriovenous carbon dioxide gradient helps you to initiate targeted therapy, get the best results. This is the summary of clinical assessment of patients. Short, and I invite you all to register for Criticare 2026, the 32nd annual conference, the Indian Society of Critical Care Medicine in Chennai, from the 27th to the 1st of March. Please do join us and share your knowledge with us. Thank you very much, and I'm now open to questions.
Thank you, Dr. Samavedam, for a nice overview of clinical approach to shock. So, fellows and folks, if you have any questions, please put them up. I'd just like to add to what has been said. Classically, shock is classified like Dr. Samavedam has shown, but certain literature now mentions a little more beyond that, and that is endocrine causes of shock and mixed shock. So in endocrine shock, which is a rare entity, definitely you don't get it too often, maybe one or two cases in a year you may get, is hypothyroid coma, that is mixed edema coma or thyrotoxic crisis. So these thyroid disorders can also have hypotension and shock, and then you have adrenal crisis, which can come as shock, and very rarely, maybe once in 5 years, 10 years, you can get hypopituitary shock, that is pituitary apoplexy. So endocrine cause of shock should also be kept at the back of mind, especially mixed edema coma and hypoadrenalism. And the other entity is the mixed shock. You know, you can have more than one etiologies. For example, septic shock, right? Septic shock classically, like Dr. Samavedam has told you, is distributive shock. But if it develops LV dysfunction, septic cardiomyopathy, so that becomes like a cardiogenic shock. And there's so many poisonings. Poisonings can have dual etiologies of shock and so on and so forth. Dengue patient starts bleeding or he has LV dysfunction, and on top of that he's leaking. So there are mixed etiologies also, and it becomes important then because we have to treat accordingly. That's just my 2 cents that I wanted to add, and I think there are no questions. Anything else you want to add, Dr. Samavedam?
Yeah, I specifically did not talk about endocrine shock because it's a different, topic altogether. It needs to be discussed in detail because see, corticosteroid insufficiency related to critical illness itself is a big topic. So I thought it will complicate the issue. So I've just confined myself.
So that's
Yeah.
fine, because that is anyway very rare, but just for sake of addition. So thank you,
Yeah.
Dr. Samavedam, sir. All the best for the conference and for the coming year as the president of the Indian Society. And let's hope we can do good work for the students and the young fellows and the young doctors. Thank you, sir.
Thank you. Have a good day. Bye bye.